Welcome to the End TB session. As you know, this is a very timely topic. September 22 this year, we had the second United Nations high-level meeting on tuberculosis. The outcome sounds extremely promising, and that we will discuss today in more details. We have a wonderful group of panelists, and we have an outstanding, they are also outstanding, obviously, and an outstanding keynote speaker. And we will discuss these points of the tuberculosis issues over the challenges and issues over the next 5 to 7 years, I would say, 27, 2030. Can we get this under control after all? You might remember 1993, the WHO, the World Health Organization, already called tuberculosis a public health emergency. And that's now actually 30 years past. And then in the Sustainable Development Goals, 2015, it was part of the program to end TB. And still, the decline you can see on the tables, on the figures, but the decline clearly is not what all of us would have hoped for. So in 2018, the United Nations decided to have a high-level meeting on tuberculosis to finally defeat tuberculosis. And then came COVID. And in 23, we have therefore another meeting, which just was 4 weeks ago. And it is this meeting that makes this issue so timely. As I said, we have wonderful speakers here today from diverse areas, from the kind of NGOs, the Global Fund, but also smaller NGOs and also a champion of tuberculosis who will also be participating today. So the first speaker indeed is Peter Zenz from the Global Fund to Fight AIDS, Tuberculosis, Malaria. We got him from the other room where he would have talked about HIV, but please now focus on TB. Peter Zenz is the Executive Director of the Global Fund, and we are very, very grateful, happy, honored that you are here to give the keynote speech to set the kind of theme for today's discussion. Thank you.
Thank you, Stefan. And yes, I was a little puzzled when I was sitting there in the other room waiting to be called up to speak when I saw a sign about HIV. And I thought, I'm not sure that's what I'm supposed to be talking about. Actually, I'm delighted to be speaking about TB because I think we are at a real crunch point in the fight against this terrible disease. TB was the worst affected of the 3 diseases the Global Fund fights, HIV, TB, and malaria, by the COVID-19 pandemic. We saw huge disruption to services and all the metrics went the wrong way. But actually, we've also seen a remarkable bounce back. To be honest, I've been surprised by how successful countries have been in rebuilding their TB services and accelerating the pace of finding people with TB and putting them back on treatment. And I think it's a fantastic achievement by both national TB programs, by civil society, by the technical partners, by the whole TB community to get us in that position. And it's therefore very timely that we had, as Stefan said, the UNGA high-level meeting just a few weeks ago, to, in a sense, capture that momentum and ensure that we build on it. And there were a number of ambitious targets that were adhered to, signed up for by all the countries, which at one level are important, but those of you like me who've been through a number of these high-level meetings know that it's all very well to sign up to targets, another thing altogether to actually deliver on those targets. And that's what we must now really focus on. So this meeting, I think, is very timely in that respect. And just for those of you who are less familiar with the Global Fund actually provides 76%, so 3/4 of all external funding for TB programs in the world. However, most funding for TB programs is domestic funding. And the critical lever, therefore, is the political commitment within the countries that have the most TB to actually make sure that programs get funded and delivered. So what do we need to do to actually deliver on the promise of the high-level meeting and on the ambition of ending TB by 2030? Well, to start with, it's not just doing what we're doing. Because if you look at the graphs and the trajectories, we're nowhere near ending TB by 2030. We're going to have a gear change, a much steeper trajectory in terms of the reduction in deaths and mortality. And there's no escaping the fact that that actually requires more money. We will certainly play our part, but we know that even though we are the largest funder of programs to fight TB, that's not enough. And the real answer is that the governments of the countries in which TB has the greatest incidence are going to have to step up the funding. And I completely appreciate that many of those governments are facing significant fiscal pressures, but frankly, it's about prioritization and the business case for investing in TB. There have been lots of analyses that have been done that show that the return on investment is extraordinarily high. We can also use, and we are using, various forms of innovative finance like loan buy-downs and debt swaps and so on, and they too will contribute. But ultimately, the thing that is really going to make the difference is government's political will to make it happen. And I am actually very encouraged by the number of governments that have taken on the challenge of TB and are determined to change the trajectory. More money. A second thing is that we need more equitable access to life-saving tools. And actually, we've had some very good news in the last couple of months in this respect. We welcome the recent price reductions for the molecular test cartridges to test TB. That has been, the price of these cartridges has been an impediment to rolling out the best ways of testing for TB. And so having a price reduction on that is a huge thing. Likewise, the price reduction of bedaquiline, the main component of the short-form regimens for MDR-TB, the 55% price reduction announced by J&J in August is, again, hugely welcome. MDR-TB is a horrible disease and one that represents also a threat to global health security. And the reality is we are not on top of it in the way that we should be. So that, again, is very welcome, and likewise the reduction in pricing of preventative treatments. I think this is the first time for a long time when we have had price reductions across multiple key tools in the TB armory. And so we absolutely need to take advantage of that and use it not to save money, but to scale up what we are doing in terms of protecting people and treating people. It's not just about price reductions, it's also around game-changing innovations, whether it's mobile X-ray or the use of AI for interpreting X-rays and for targeting case-finding efforts. There's a whole range of innovations that we need to leverage. And I think we have to be honest with ourselves that TB as a health community has had a history of actually being rather slow in adopting innovations. We've got to change that. There are too many people at risk, too many people who are dying. We need to get these innovations to the places where they can make a difference as rapidly as possible. Why should we focus so much on TB? And the reality is the world has tended not to focus on TB. I can tell you, in running the Global Fund to fight HIV, TB, and malaria, the one we're constantly having to push to put on the agenda is TB. HIV has a long exceptional history of global activism. Malaria has the, and I don't want to have this misinterpreted, it has the advantage from a kind of marketing perspective that it kills children and pregnant women. It's very easy to tell a compelling story around malaria. TB has always been the one that hasn't attracted so much attention. But I'll give you 4 reasons why we should care about TB. One, and I realize I'm probably preaching to the converted anyway, but one is simply, this is a very effective way of saving a large number of people's lives, particularly from the poorest and most marginalized communities in the world. In a sense, you shouldn't need much more than that as an argument. Second, TB affects people who are often of working age and takes them out of the workforce for a significant period of time, even if they are being treated successfully. I've looked at the work of some companies who've taken on this burden themselves, Anglo-American being an example, and the business case for a company for reducing TB incidence in its workforce is absolutely compelling. So even if you are callous and uncaring and don't care about people's lives, there's a very strong business case. Third, TB is a proven route towards UHC, because actually many of the things that you need to do to put UHC in place are building blocks for the fight against TB. Now, that's not just a theoretical point of view, it's actually what Japan did in the 50s and 60s. In 52, I think it is, Japan launched a national TB program, which was a comprehensive program that extended primary health care, reached out to marginalized communities, created a whole apparatus of public health. They then used that in 1961 or 1962 as the platform for creating their UHC. And actually, if you look at the history of what Thailand and Korea did, it followed very much the same kind of model. And then finally, and fourth, TB is also a proven route, or fighting TB is a proven route to building effective pandemic preparedness. For many low and middle income countries, the core of their response to COVID-19 were their TB diagnostic labs, their TB protocols around infection prevention and control, and indeed the leadership of the TB programs. One of the reasons TB got so disrupted was that quite a lot of the leadership was actually diverted to fighting COVID-19. So this is the right moment to step up our fight against TB. As I said, I am impressed by and hugely supportive of the leadership of a number of different governments, some of which I know are represented here, which have really taken on that fight. We as the Global Fund are committed to supporting it, but it will require the whole partnership. It'll require communities, civil society, technical partners, private sector partners, and also a willingness to overcome some of the non-medical barriers to access. Criminalization, discrimination, stigma, these are barriers that will impede the effectiveness of any biomedical approach unless they are tackled. So with that, thank you very much, and I look forward to hearing the rest of the panel. Thank you.
Thank you, but we should take the opportunity to have you here also to have questions, burning questions, to Peter Sands. Thank you first for your wonderful overview. And my question will also come then sooner. What gives you now the optimism that it's different than the years before? And what can we do to monitor and see that after 1 year, 2 years, 3 years, a change has started? And then we come to your question. The microphone, please, down there.
Can I answer your question?
Yes, please.
When I joined the Global Fund 5 years ago,
Yeah.
And when I joined the Global Fund, one of the first things that struck me was that the mood in the TB community was very different from the mood in the HIV and malaria communities. Right. There was a bit of a kind of fatalism in the TB community and a sense of, you know, we're never going to get on top of this. What I see is really different right now is a sense of confidence and energy. We've got political leaders like Prime Minister Modi in India, ministers of health like Pak Budi in Indonesia, who are really driving from the front on this. We have innovation that is changing the game. We have price reductions that are making the economics of the thing work better. So there's a real sense of we can do this, I think, in the TB community that I haven't really felt before. Now, we need to hold ourselves accountable. We need to be confident that if we're standing in this room a year from now, that the numbers have moved in the right direction and that we've really made it happen. But that's what gives me optimism, is that sense of kind of confidence and determination, which I think is greater and more intense than I've seen in my 5 years doing this.
Yeah. So you talked about turbocharging the whole system, and that would give us the benefit. What do you mean turbocharging? Is that the politicians are more to be engaged, or everybody, the community, obviously everybody in the field?
Well, I think when you're fighting a disease as formidable as TB, there isn't a single bullet, a silver bullet. There isn't just one thing. And what you actually need is to get multiple dimensions, whether it's the money, the political leadership, the innovation, the access, all moving in the same direction. And I think we have that. It's not automatic. We've got to make it happen. But we really have the ingredients to sort of turbocharge our progress on TB right now in a way that we haven't had.
There was a question to the right from my side.
Hi, thank you for a very kind of, nice keynote. I'm Dr. Vikas Agarwal. I'm from International SOS, which works on workplace interventions with the private sector on tuberculosis as well. One thing which I want to say that I think workplace intervention at scale has always been a gap. It has been there, but we really need to do workplace intervention and private sector as the kind of, big stakeholder, but it needs to be scaled up. And the major issues is kind of, like, although funding from the private sector for their own workplace intervention is okay, but also there has to be need of much more kind of, support from other funds, from other, agencies like bilateral and other. Any thoughts on that, how it can be scaled up, because it needs to go to the different level, because workplace could be a good entry point for tuberculosis. Thank you.
I completely agree with you. I mean, the Ending Workplace TB program has actually been very successful and growing, but there are an awful lot of very large and small companies in countries with high incidence of TB who are not involved. And we should get them involved, because it's demonstrably an effective way of identifying and treating people with TB. And as I said, it makes business sense. I come from a business background. And what I do is when I meet company CEOs who have large operations in Bangladesh or Indonesia or India or Nigeria, I say to them, if you've got 10,000 employees, you've absolutely got people there who have TB. And it's actually not that difficult to identify them and put them on treatment. And I think we need to make, I agree with you, we need to make that case even more strongly, and we need to scale up the numbers so that it is millions of employees who are covered by those sorts of programs. And of course, the logical thing is you don't stop at the employee. You go into the family and so on, so you cover an even greater number of people.
Thank you. Further question to Peter Sands? That's not the question, so thank you. So now we come to our panel discussion, and I would like to have all panelists come to the stage. It takes a short time, but it's an extremely exciting panel of experts from all different areas. It's probably one of the most diverse panels I had the pleasure and honor to chair today on tuberculosis. And I will say a few words about all the panelists and then introduce them if there is need in more detail as we go through the panel. And if you don't mind, I will also sit down. And so my name is Stefan Kaufmann. I'm a emeritus founding director of a Max Planck Institute here in Berlin on infection biology. And I'm mostly a researcher and spent some 40 years in researching tuberculosis. And I very early in my life recognized, actually through WHO's SAGE activities, which I had in the late 80s, I realized that my research only makes sense if it's in the context of global health. So I developed biomarkers for prognosis of TB with all the partners, mostly in sub-Saharan Africa, and also vaccine, which is now with the Serum Institute in India in several phase 3 trials. So I'm hopeful that this can also somehow contribute in the future to the defeat of tuberculosis. But I'm the moderator and not a speaker today. So this is the great panel that we have today. And we will ask everybody here to give a couple of minutes to give their major points. Specific questions will be allowed then, if they are very specific to that talk, to clarify issues. And I would like to have then a more general discussion, suggest to you to have a general discussion at the end, because if you have all these questions in between, that has advantages, obviously, because you still remember the question, but it also has disadvantage that you might hear from others, and the full picture is only seen once we have the whole panel having their contribution. So to the right to me is Suvanand Sahu from the Stop TB Partnership, an organization that is, I would say, instrumental for tuberculosis to be seen on the platform and on the discussion round. So I'm really eager about to hear live from you and all the others. Next one is Katharina Böhme from the World Health Organization. She was with FIND and in TB, but she's still obviously the right ideal person to give the overview and perspective from the WHO. Next, Atul Gawande from the USAID, one of the major sponsors of bilateral activities, including tuberculosis. And he's there as assistant administrator. And we are eager to listen to what your ideas is from this important organization. Then Dr. Rafilo Macchi, founder and CEO from Equity Innovations. And you will, I guess, see the point of care situation more in South Africa. And I'm very, very happy that aside from all these more general views, we also get two, one is you, views of the more specific needs that are at the place where the battle happens actually. And I'm eager, we are all eager to listen also what you have to say to us. And finally, we have Eloisa Louis Sepeta Teng. She probably knows tuberculosis best because she is a TB champion who went through all the difficulties of suffering from tuberculosis. She suffered from meningitis, tuberculosis meningitis, and this was even drug resistant. So that had also adverse events, I understand. But she's a hero who went through all that, even though she is now blind. She's the mother of 2 children, and thanks also to her husband, who helps her to be here. Thank you so much for being here and telling us your story in the context of TB eradication programs from a very personal view, I assume. Thank you so much, everybody, for being here. And let's go into discussion. Sahu, you are the first. If I missed anything, just tell.
Thank you, Professor Kaufman. It's a pleasure to be here. My perspective is from the Stop TB Partnership, which, as Professor Kaufman described, is a global partnership to end TB. So let me start, after listening to Peter, who articulated it very well. Let me point out that TB can be prevented, diagnosed, treated, and treated to cure. Yet, we have 1.6 million people dying of this disease each year. This is simply unacceptable. Now, let me reflect a bit on what happened. There was an interesting question on the timing of this, and what happened this year in September 2023 is the UN high-level meeting on tuberculosis. First, because I was engaged quite a bit throughout the process, let me point out some of the things that I would call as not so good things, and then I will come on the good things.
Good.
So first, getting to the not so good things. It was a high-level meeting, but it wasn't as high-level as we would have wanted it to be. Why? Because the heads of states did not participate in the actual meeting, with the exception of one head of state and maybe one or two deputies. And this may be because it was on a Friday in a busy high-level UNGA week in New York, so we couldn't get them. But the health ministers and the foreign affairs ministers were there, and they made good commitments in the meeting. Second, some of the negotiations that happened in the run-up to the UN high-level meeting were quite difficult. Relative to 2018, we saw countries having very different perspectives on many things. So because of that, we always thought that perhaps there is a risk that the political declaration may not be approved, but it was good to see that it was endorsed by the meeting. Third, I would point this out. I think Peter said very nicely that TB is a proven way towards UHC, and the example of Japan, and also how during the COVID pandemic we saw TB can be a proven way towards pandemic preparedness. However, these 3 UN high-level meetings were happening on consecutive days. We tried from TB to reach out to the stakeholders, but it was difficult. Now let me reflect on some of the good points. The meeting happened. What gets left behind is the political declaration. We are very happy to see that in the TB political declaration, there are some numerical targets. When you have such targets, accountability is easier, measurement is easier. We need to treat 45 million people for TB in the next 5 years. Very clear targets. 1.5 million of those drug-resistant TB, 3.5 million children. We also have targets on the funding that needs to be mobilized. $22 billion for TB care and prevention on an annual basis. And in addition, $5 billion for research and development on an annual basis. If you look at where we are, it's about 1/4 of that money is available. So great commitments in the political declaration. Now, the second thing that happened, and I would point out as very good, is the engagement of the civil society right throughout the process, and also very visible in the UN high-level meeting. I was also there in the PPR and UHC meeting. I didn't see that level of engagement of the civil society. So that is a great thing that we need to follow up also. Besides the UNHLM, that week in New York also created a momentum in the global fight against TB because of a number of announcements and side events that happened. Announcements that were referred to by Peter, price reductions. 20% decline in the price of the Gene Expert TB test cartridge. 30% decline in the 3-HP regimen for TB preventive treatment. And the drug-resistant treatment, BPAL regimen, the short BPAL regimen is now down by about 50% in price. Great announcements. We also had WHO establish the Vaccine Accelerator Council. We know that vaccine is needed, a new effective vaccine is needed to end TB. We also had Stop TB Partnership launch a coalition of leaders against TB, and we have to work further on it. So all these made, these were positive points coming out of New York from that week. And I think this created a momentum that will be great for the global fight against TB. Now, the challenge comes, how do we put these things to action? And I would say 4 things here. I think Peter referred to some of them. First, it is very important to maintain the political commitment. It's not just people come and during the UNHLM process commit and then there is no action. So very important to engage the heads of state, not just the health ministers. And we saw how things have moved in India because of the engagement and leadership of Prime Minister Modi. Also in Indonesia and a number of other countries, heads of states are speaking on tuberculosis. It wasn't there in the past. We need to build further on it. Second is funding. As I said, the current funding is 1/4 of what is committed. How do we get there? Peter gave some ideas about domestic funding increasing. We saw that in some countries, but some countries will require external funding. The TB community has been pushing Global Fund to devote more of its resources to TB. TB kills more people than HIV and malaria put together. So it is unfair that TB gets only 18%, 18% of Global Fund resources. But we also know that innovative financing can bring new money into TB. We saw that in India and Indonesia, how results-based financing and the collaboration between World Bank and Global Fund can get new money for TB response in the countries. My third point is about innovations. We have, I think more people will talk about innovation. I just wanted to mention that today, the way you diagnose TB has changed. We have ultra-portable X-ray machines. We have artificial enabled reading of the X-ray machines. We have battery-operated rapid molecular tests. These things bring TB diagnosis to the community. We have treatment. Imagine drug-resistant TB treatment a few years ago was 18 months. Now it's down to 6 months. And simple treatment, not so complex and not injections anymore. We also know that there are 15 vaccine candidates under research. 5 of them are in clinical phase 3 stage, and some probably very close to having the results. So innovations are there already, and some more are coming. The challenge is how do we scale it up? And my last point is that in a disease like TB, you cannot end it without community-led actions. No longer just engagement of community, but communities have to lead. And a lot of work has been done, initial work. We need more investments in empowering the communities to lead the fight against TB. And I would close by saying that we need a sense of urgency. Professor Kaufman, you said 1993 was when the emergency was announced. Today in 2023, we have 7 years to go. And we saw what urgency and the sense of urgency can do in the COVID response. We need that in TB. Thank you.
Thank you. Are there direct questions? Does not seem to be the case, and we save that then for the general discussion. And I move forward to Katharina Böhme to provide a kind of view of the WHO.
Thank you so much, Stefan. I recall that we sat here together in a similar panel in 2018 at the occasion of the first high-level meeting and declaration discussing the big gaps in TB diagnosis. And so it's very timely to be back here today. You know, I'm now far, far, far from being a TB expert, but I may have the advantage of looking at it with a bit of an umbrella view. And, you know, so from my perspective, the UN high-level meeting, of the 3 meetings of health, the others were on UHC, universal health coverage, and pandemic preparedness and response, was by far the most energetic. It was by far the most concrete and ambitious in terms of its targets, you know, and I feel it did most to bring together all stakeholders, from member states to communities to civil society, you know, and I want to take a moment here for all of us to clap, to thank especially civil society and community. You know, as Peter said, this meeting was so much needed because it's political will that we need most to make progress in TB. The targets are ambitious, yes. We need to reach 45 million with treatment. We aim to, you know, to provide social benefit packages to all people with TB, to license at least one new TB vaccine, and to fill the funding gaps, both for TB implementation and research by 2027. Now, when we look back at our WHO stock take compared to the 2018 targets that were in the first declaration, it's very much a view of the glass is half full, right? Because when I read through where we are and the progress we've made, there's a lot of 50% I see in terms of what we achieved. We achieved to treat 55% of the multi-drug resistance patients that we should have reached compared to 2018 targets. We gave preventative treatment to 50% of the number of household contacts under the age of 5. You know, and in countries, we saw less of 50% of the domestic financing that would have been needed to reach the targets. And at global level, only 50% of the funding has been mobilized compared to what we strived for in 2018. So, you know, I think overall, of course, this was affected by the pandemic, right? By the most severe pandemic we've seen in the last 100 years. But nevertheless, you know, let's do better this time. We have to. And as Peter and Sahu said, implementation is key, right? So how do we get there? We have a lot of important tools, and we have the policy and the policy guidelines to drive progress. So as WHO, we call on countries to join our flagship initiative and to join all partners here in the room to drive progress. You know, Indonesia, India have already been mentioned as leading this, but I've recently been in Vietnam, for example, and also there I see great political leadership, you know, again, also mobilized by civil society, and you know, it's a real stark difference. Brazil, we've recently met with President Lula. TB was one of the first words he mentioned in the bilateral meeting. So we do see a difference, and we do see a different commitment. Having said it, as WHO, I cannot not mention accountability. Our WHO multi-sectoral accountability framework has been joined by over 100 countries, and we will be measuring very concretely the progress against the high-level declaration with the commitment of countries and with leadership and help from civil society and again, the communities. So that will be absolutely critical. And Saho, as you said, last not least, the TB vaccines in the pipeline are, of course, a big reason for hope. You know, we have a number of them in phase 3 trials. They're unlikely to help us in the next 5 years to drive progress, but if we have one in 5 years from now, that would be a big success. Therefore, we launched as WHO this vaccine accelerator at ANGA together with many partners, and that's why we put so much energy in focusing on getting the last tool we need besides the progress that you've heard about on the diagnostic front, although as a diagnostician I must still say we need a lot of progress on the diagnostic side as well. But so overall, you know, let's use the innovation we have while we work on more. And then last word, multi-sectoral and integrated, I think is something that Atul may also mention, right? The integrated approach to TB as part of, you know, the general agenda on primary healthcare strengthening, I think needs to be much more emphasized going forward. Like Saho, I'm sad that we weren't able to bring those meetings closer together. And I think we need to work on this together over the next years. So just in summary and to close, we clearly need all hands on deck to translate all the commitments that have been made into action and reality, and we need all the partnerships we can get to do so.
Thank you. And again, the floor would be open for direct questions. So everybody seems to be fully online with you, but we come back to the questions importantly at the very end. And we will now hear another view from UNAIDS by Dr. Atul Gawande. Thank you for sharing your ideas.
And from USAID, so that's all right.
Yes.
But delighted to be here. So I think you've gotten the data already from the previous speakers. So let me just try to say a few things to describe what will it take for us to actually get there. I was in Addis Ababa, Ethiopia last month, and I was there for a primary healthcare conference, but I would sneak out between the meetings in order to visit a couple of centers. And one of the first places I got to visit was St. Peter's Hospital for Tuberculosis and Leprosy. Mm-hmm. And there are people there who have been there for months, 8 months, 10 months, 12 months, getting treatment for drug-resistant TB. One of the people that I met was a 31-year-old mother who had 4 children. And she had fled Oromia, where there had been violence and conflict. And then in the conditions where she was forced to stay, crowded conditions in Addis, she ended up getting TB. Mm-hmm. Inadequate treatment led to it being drug-resistant TB. Mm-hmm. The lack of follow-up to ensure that her children were protected meant that all of her children developed drug-resistant TB. And there they were in the hospital. 8 months in, having successfully been treated because of bedaquiline and the BPAL strategy. But what a loss. Almost a year in the hospital, these beautiful, now healthy children, ages 2 to 13 years old, and this woman who was healthy again, weight up, but still had the hollow, dead look in her eyes of now, where does she go? How does she return? Because this is a disease, as we know, of the downtrodden, of the poor, of the displaced, and we're at the greatest level of displacement, more than 100 million people displaced because of violence, because of climate. And also some of the highest levels of food insecurity and malnutrition, making TB happen. Now, the other places I got to visit with Minister Leah Tedessa, the Minister of Health, was going to the primary health centers and seeing exactly what it takes to be able to address the issues. It was where their primary health services had broken down because of conflict that TB had emerged. But where they had their exemplary community health worker program, Ethiopia is not a high-income country. At less than $50 per person per year, they are able to commit to more than 3/4 of their budget going to primary health. And that has meant paid community health workers trained at least 12 months who are able to belong on teams that has one health worker for every 500 households. That means touching a total of about 2,500 people. And able to touch those households at least every 3 months. And for high-risk people, they would be able to touch them as much as needed. So when I visited a primary health care center, you saw what that actually meant. It meant a community health worker who knew in their community of 500 households that they had 7 HIV patients, that they had 3 critical TB patients. They knew that 2 days before, one of those TB patients missed their follow-up appointment for getting their medication. And then they had tracked them down, found them, saw that they were in a family of 5 where the one sister was the only employed person. They were not having enough food. They were clear that they were not clear that they thought that taking the TB medicines would make them even more malnourished. They needed education and persuasion. And it took not just one day, it took a second day and a third day before they continued and got back into care, and then continued to have that accompaniment that makes it possible to stay on their treatment, and then to make sure everybody in the family got their preventative treatment and connection to social protection services to the extent possible for having their access to food and being able to address those critical issues. It doesn't always work perfectly that way, but that is how it is successful. In the 1950s, the US virtually eliminated TB, like in Europe, like Korea did, like Japan did, by a straightforward strategy that we have known over time. You have to reach out to people and screen them. And at that time it was chest x-ray, just as today. You had to make sure that once screened, the people identified as at risk of TB then got onto treatments, and there was toxic antibiotics at that time, and then in isolation, and then identifying through contact tracing the key contacts in the household who are at risk and making sure that they were getting onto treatment. And that was successful with 1950s technology. Today, at much lower cost, much lower intensity, you heard all the pieces that came together here. Thank you to J&J for the 55% reduction in cost in bedaquiline for the drug-resistant TB. That means we can more than double with the existing amount of money the number of people reached. Thank you to the various manufacturers of rifapentine who agreed to 30% reduction in preventative treatment costs so that the families could get on preventative treatment who have family members who have TB at much lower cost, and these short course regimens are easy to stay on, 3 months, once a week treatment. Thank you to Cepheid and the reduction in the cost, 20% of the GeneXpert cartridge for the standard TB. Thank you to the manufacturers of the CAD4TB chest x-ray systems so that we are able to now do chest x-rays and get an immediate reading, then get an immediate molecular test and put people on the same day onto treatment and trace the kids and get them onto treatment as well. That is how we will be successful. What we ask is, as was noted, that comprehensive approach is what's necessary, and that means being able to bring those capacities down to the community level through community health support. That means domestic and local commitment to community health workers and the integration with primary health care, commitment to providing their capability to deliver this whole regimen. Often we may bring the treatment. We may bring the screening and the treatment, but bringing the screening, the treatment, and then the contact tracing, followed by preventative treatment, that is what eliminates the disease. Finally, I'll say we did announce a number of different things besides the treatment reductions and the cost reductions. And all of these things don't happen on their own. They happen because of determined partnership with the private sector, with governments, the Stop TB Partnership, PEPFAR, the Global Fund, all of us getting together and negotiating these capacities. But then it's also the country support that uses them that's absolutely critical. We also announced what's called the Breach TB trial, which is to yet further simplify the treatments. It's testing a 1-month course of bedaquiline as an oral bedaquiline as a way to prevent TB, to make it even easier, and it lays the platform for when J&J's long-acting injectable bedaquiline comes to approval, to test the idea of a single injection to prevent TB, to make it tremendously easier for those who are exposed. That would be a game changer, along with the vaccine trials that there are. Finally, we announced, because we know conflict settings are so critical, Congress did give us continued funding for TB. So far, the US government is on track to be more than $5 billion as the largest bilateral donor towards TB, plus backing Global Fund as its largest donor. And we announced 2 new sources of funds. One is $8.5 million specifically for conflict settings, knowing that those are critical drivers, and specifically includes Burma, Afghanistan, and elsewhere. And then finally, $15 million that we announced where we, as a challenge for 1 or 2 countries to come forward with co-financed approach to the comprehensive approach to demonstrate in at least a region of the country, if not an entire country, that we can eliminate TB as a major public health threat in a low or low middle income country, the same way that we have done in the high income countries. We are looking forward to hitting this goal. We can deliver on the SDG goal for eliminating TB as a public health threat through a combination of innovation and our partnership and commitment.
Thank you.
Thank you.
Thank you for also all the 3 of you pointing out that it's equally important to treat for therapy, but also to treat for prevention, because this is the only way to get numbers down where we want to see them. If there are no burning direct questions, I'm a little bit hampered by light, but I don't see any question. I think it's a wonderful continuation now, what we heard from, if I may say so, bird's eye views now to the ground and the point where things happen. And therefore, I'm very glad now that we have Dr. Rafilo Machi from South Africa to tell us from her NGO standpoint what is needed most to achieve those goals on paper to become reality.
Thank you, Prof. And really, it's wonderful to be here. And it does not happen often that one has an opportunity coming from a local perspective to be talking with the global leaders. You know, maybe it's just reflecting the first meeting that we had on TB was exciting. Goals were set, and unfortunately, COVID came in, so it was still a bit difficult for the countries to go back. We all used COVID as an excuse why targets have not been met. But here we are, we went for the second UN high-level meeting, and I'm happy, Dr. Sau, you have already mentioned the issue that what I found a bit disappointing is that the people who were responding about this the targets were the same people who have to deliver the services. Very few actually even said, why did we not meet the 2018 targets? So that also I thought was a missed opportunity. However, I think we need to live here also understanding that for people working in TB, these opportunities do not come often. And if we do not act now, it will get to a stage where communities just say they are going for another new set of targets. So we really need, again, a plea also to the global communities and the funders to say, can we make our countries accountable? It's 4 weeks coming back from the meetings. Have the countries even started looking at their policies? Because we set new targets, we continue doing what we've done, and we achieve the same results. Now, one of the things which also I think related to the diagnostics, it's from a government perspective, having a good diagnostic in a laboratory, it's excellent. But what are the costs of taking a specimen to that laboratory? So from a NGO perspective, it's looking at, there's a transportation cost to take that sample. Where's is the transportation cost of the client, firstly to reach a clinic, Thereafter, a specimen is collected. There's a transportation cost to take that specimen to a laboratory. Now, however wonderful it is that today we're talking of a turnaround time of 90 minutes, for the patient, in some countries, is up to 1 week. Now, for someone who's sick, who's just told, you'll come back when your result is available, it's not acceptable. We know that majority of our patients are coming from low socioeconomic status. We meet with patients who said, I have already borrowed $5 to come to the clinic. Now, when you're telling me to come back tomorrow, where will I get that money? I think there are certain things that as the TB community we need to do differently. Now, the new targets, they are ambitious, but I think they can be achieved if we change our strategies. We need to look in the short term, what will we do, medium term, and long term to achieve the targets that have been set. Also, a good thing is that even though the focus of delivery of TB services is related to health, we need to engage other ministries of health. We're talking of social services. When will we start hearing from our ministers of social development to say, how do we support people on treatment? There have been good programs where patients are being given food packages, but it's so sad when you go to a household where a mother or a father comes with food, she gives it to the children. So we need to be more comprehensive, think of people rather than treating a disease. I think for NGOs working maybe closer to the communities, we need to think of the involvement of community healthcare workers. Believe me, they do amazing work because they can talk to the communities, they are much closer, and they can be used in a much better way. And many countries talk of community healthcare workers as volunteers. Mm-hmm. They need to be paid because they do an amazing work. The delivery of TB drugs, it's another area that we need to look at. It's too clinic-centric. Treatment might be for 6 months, but we are also not looking at the feasibility of those people coming every month to a clinic to collect drugs. This is where NGOs and the communities can take the drugs to the patient homes. I'm not even talking about strategies to reach people with disabilities. They are dependent on other family members to bring them to the clinic. Not much is being done in that regard. And I'm also happy that we also heard already from our chief here from the Global Fund. The Global Fund has taken the TB programs to a different level in many countries. But the same countries also need to be accountable and say, when you do not achieve what you have proposed to do, what should be done differently? Innovation we've talked about, and many countries have already conducted their prevalence surveys. And it was clear that more than 50% of people who already have active tuberculosis do not have the symptoms we always talk about. So at what point are we going to be actively screening communities to identify and diagnose TB before people get very sick? So I think it's something that we need to think of. The tests, there's a very good test that has already come up, the TB-LEM. It's a good test, it's already saved lives, but if we know that it's also targeting people who are very sick, and we should avoid for people to reach that level. It would be great one day to be talking of a test that can be administered in a household, and people are initiated in treatment. And really, in closing, maybe again a plea again to our funders that the prices of drugs and diagnostics have dropped, but we need to be careful that 5 years later, we do not talk of resistance to bedaquiline. Because if we are going to provide it much easier now to the countries without safeguarding it, that's the only solution that we have for now. And we quite often talk about these new diagnostics. Let's not forget children. Children are susceptible. Today, we don't really have a good test to diagnose TB in children. So as we look at new diagnostics, let's remember children. And I think in closing, really, it's a good opportunity, and thank you for the global community for making noise. But us in the field and the civil society, let's continue making noise to make our countries accountable. Thank you.
Thank you. Can we have the microphone here? You wanted to ask a question, right? Yeah? Or comment. Thank you very much, and it's, I really like this discussion round here. It's really from all angles, and that makes it really very, very fruitful.
Thank you. My name is Liliana Pacheco, and I'm a student at Charité. As someone that grew up in a developing country such as Peru, I know how heavily affected have been my people. And I consider and I appreciate so much you all mentioning the role of prevention in it. I'm aware that undernutrition and malnutrition is a huge factor in this. And according to the United Nations Food and Agriculture Organization, we need to put in place food systems that increase the availability of nutrient-rich food for everyone. How can we achieve this in all sorts of countries, not only developing countries, but also developed countries who show extreme high levels of malnutrition?
Who wants to answer? Who wants to comment on this?
Okay.
Please.
You?
Okay, maybe I can, still looking at our countries mostly affected by tuberculosis, is the integrated approach. We have very good programs where we target children, weigh them, but we miss those opportunities to say, when this child is not gaining weight, could it be TB? You find that children that are finally diagnosed with TB have been to health services several times, failure to thrive. The same diagnosis going ahead, but we need to really make sure that we provide integrated services in order not to miss opportunities. We know the diseases that affect our countries. When we go to a family, let's talk of tuberculosis, let's talk about malnutrition, let's talk about HIV. And just lastly, when you think about it, HIV today is a routine test, which initially was a major challenge. And I hope one day we'll talk about TB being a routine test, not to miss the opportunities. Thank you.
If I can add something on the nutrition question, it's very important because globally, if you look at the determinants for TB, nutrition is an important one. 1 in 4, as much as 1 in 4 TB could be because of undernourishment. And this is very important in the context of what we are discussing, because TB is not just a diagnosis and treatment issue. It is a wider medical issue. It also has social and economic dimensions. So that's why it is very important to have all of a government response and all of a society response. And in this context, I'll just mention that we have a good example of it, and I would encourage you to find out more about it. There is a Prime Minister's TB-Free India campaign where nutrition is being provided to people with TB in a very interesting crowd-funded model that also breaks stigma, but also contributes to improving nutrition of the patient, but also the family. Thank you.
Okay.
Sure, I'll just say a couple things briefly. One is part of the massive rise in malnutrition as well as food insecurity has been conflict. In particular, the government of Russia's invasion of Ukraine and then the blocking of the Black Sea ports have dramatically reduced the access to basic wheat and have driven up prices. So it is very important that we come together as a world to come behind the effort to stop and support Ukraine in getting back on track, on returning to the government of Russia leaving, and opening up the Black Sea port. Second, when we talk about malnutrition and hunger in the highest risk TB populations, it's under conditions of crowding and under conditions of poverty. You see it in prisons, you see it in humanitarian and conflict settings, and even within peaceful countries, the places where you see internally displaced people or refugees. And so these are some of the least valued environments, and it's absolutely critical that we have transparency about hunger in these settings, that we expect and drive support. The United States is one of the biggest, is probably the largest bilateral supporter of food aid, as well as addressing malnutrition and rapidly therapeutic foods. And that, I think, is a critical element. Finally, I'll say, and I saw this in Ghana, where it came to life, is that when you have a core primary healthcare capability, community health workers who are regularly screening, measuring weight and height, looking at the condition of children, that is when you surface acute starvation, acute malnutrition, and as well as stunting, and then are able to create awareness and visibility of the problem, and then link people to services, as well as access to therapeutic foods for acute situations. All of these are critical parts of our ecosystem for making this happen.
That's true.
Thank you.
Can I just
Yes,
very
please,
briefly
sure.
add
Yeah.
to it? Completely agree with everything that's been said. And just want to add that besides conflict, a big driver that makes the situation worse is climate change, right? When you look at the Sahel zone, for example, already today, the migration with the heat waves, the rapidly rising temperature that make whole areas unlivable, basically, right? I do think we're collectively not yet prepared to respond to that. The World Food Programme is only 60% funded for this year, and clearly working on that challenge together and looking at it in a multi-sectoral way, I think is one of the greatest challenges we have ahead of us. So, thanks for raising that. And then, also just a quick comment on people being pushed into poverty, right? Because one of the cross-cutting challenges we face also in fighting against TB is that alone in 2020, 2021, we've seen 400 million of people being pushed under the poverty limit because they had to pay out-of-pocket expenses for health, right? So
Thank you. Yeah, it's already the general discussion. Can I suggest we have one more speaker, and I would like to give her now the time to give out her very impressive story to tell, and then go into the general discussion further. I've not cut you down. We come back to you for sure, and you will be the first of the in the general round. So we come to our last speaker, Louise-Sepe Teng. In 2007, she was paralyzed and nearly died from meningitis. It was misdiagnosed, and it turned out to be tuberculous meningitis, reminding us that TB is not only a pulmonary disease. She survived, and now she's a champion. And I think it's very important also to listen not only to the broad talks, but also to the very personal challenges that come up with TB. The stage is yours.
Okay, thank you so much for this invitation. My topic is reach more of the unreached, and the focus I want to highlight is the disability sector, where I'm now part of, and also the youth. I'm also the founder and president of TB People Philippines, an NGO for survivors, those who are affected, and also close contacts. Before I actually created this organization back in 2020, before the COVID situation, I was part of the Disability Federation in my city, and I was hiding the reason why I went blind, because I might be double discriminated for having disability and having this kind of the communicable disease. And I heard somebody coughing from the deaf community, and they told me the member went to the health facility, but due to there's no translation in the job aid of the health workers, he was said, go away, because we don't know how to do sign language. The member just did not go out of the house anymore. We believe the person died. So I think that was one of the reasons why I had to say, I have a mission. I'm not here just for a second life, but I have to do something about my sector. After I created the organization back in 2020, the first sector that we were able to invite in our live show, we have a Facebook live show, because during pandemic, you cannot really go out. We created this Facebook live show. Social media is our tool. And the first group that we got to listen to us was the Youth Council. Youth Council is actually created in all of the cities in the country, and they have direct support from our local chief executives. And they told us, this is the first time we heard of tuberculosis. And even if they have the means to actually affect their sector, the youth, they have no direction coming from our local authorities. I was very connected to my invitation last year from Johnson & Johnson's TB Warriors. I said, that's a very cool platform to have that online game. It's like a Where's Wally? That's what my husband told me. It looks like finding the bacteria in that big picture. I said, even if it's very basic, still, my audience, my group are actually entertained. They like the idea that, this is a different side of how to look at this disease. And they won prizes. It was very, very cute, but I think my members are actually having fun with the initiatives of my organization. Last year also, Stop TB Partnership also provided my organization the challenge facility for civil society. And I focused again for my sector disability. I was looking for qualitative data regarding what could be the cause of their disability. Even if we have the United Nations Convention on the Rights of Persons with Disability, still they ended up like me, having this disability. And we were able to collect all of these issues on depression, issues on the injection. Here, I was also one ear, my left ear actually was sort of hearing impaired, but therapy helped me get it back on track. I don't want to be Helen Keller that time. So, and then we were able to get this story. He had the drug-sensitive TB, but then again, he ended up not being able to walk. So we went to his house. We found him naked. He was, lying down on a tarpaulin, so that if ever he pees, it'll be easy for the son to rinse him. But the thing is, we were checking out the possibility why he's not improving. I said, have you had any other laboratories? He said, no capability. I was only able to give him some cash, and he cried. He told me, I hope I'm having the right medication, because I don't have anybody to carry me to the facility so I can be properly diagnosed. But the health facility said that they're giving him the medication. He did not survive. He died this new year, 2023. And I was just really, if only I had met him earlier. Maybe he's with us in the association. Early this year also, we had a country dialogue for Global Fund, and thankfully I'm one of the CAP committees in the country. And we were talking about this effort from Global TB Alliance, the leveraging innovative faster treatment for tuberculosis. And I'm one of their consultants to be able to really help Filipinos understand the new novel regimen, BPAL. So we were able to enroll 103 Filipinos, and it was 98% successful. And I was there trying to ask, how do we do the checking of the regions? We have 17 regions in the country. We need to look for ways to check the readiness of all of these regions. I told TB Innovations under USAID, can I join you? I mean, I'm a civil society. Can I just join you? It's for free. I want to really look for ways on how to make sure that there is readiness enabling environment for all of these new tools and new regimens. And I was able to join them in the regional visits. And I was doing patient management assessment. So that's my role there, to check this, to do this checklist for them. And I was checking if the patient understands bacteria. One informant told me, TB comes from coffee. So it was like, so there's still stigma here. So it means that the information is not really reaching these geographically isolated areas of the country. And then I was asking, do you get your laboratories on time? Do you understand your laboratories? Do you understand how to make yourself, have the proper nutrition? No. So it's just, you drink the medication, you go home. It's up to you if you understand what's happening to your body. And it was just maybe phenomenal that one of the informants was actually blind as well. And I asked her, so who's taking care of you? The sister who is able to assist her to her monthly laboratories. But recently we were informed that all of our enablers, the enablers is more of like a money, $20 a week. We give our DRTB patients for the means of transportation because we only have one laboratory facility in a region. So it's like we have 17 regions, but we only have one laboratory facility, which is like 6 hours away from where you live. So if that's going to be taken out for this new law that we will be anticipating in January 1, that all of these regional facilities will be taken out, all will be decentralized. It will be easier for them. There's no more need for the $20 a week. And when I told her about that, okay, no problem. If the facility will be near me, I don't need to I don't need to rely on that $20 a week anymore. We have a problem. I went to the mayor's offices and I told them, are we ready for the enabling environment for the new novel regimen? They said, next year, maybe. We don't have the funds for laboratories. We don't have the funds for manpower because due to this new law, the nurses that we have right now is 200 nurses. It's going to be just 120 nurses. All of them are taken out of their work. So I'm just really looking for ways, how do we do that in a couple of months, that all of the drug-resistant treatment, not in a special facility, it will all be in those primary care facilities with lacking trained health workers, lacking laboratories near the residents who are affected. So that's where I started doing the political commitment. I went around the country and looking for, could you please tell me #6 months max? I will commit to the lesser pills, lesser treatment duration. And I've been getting like 8 mayors now giving me the video commitment. And after that, it was now going back to the World TB Day. And one of my survivors, who's around 19 years old, told me, he calls me Tita. Tita is auntie. Tita Louie, my story was featured in the local news. And then they told me about all of these possibilities of going around the country also to be a spokesperson. But the problem is when he went to his school, so many of his classmates were actually asking for his time, asking him how you did the treatment because they're not guided. All of them told him that they also have TB, their parents get their medications for them, but they don't have that orientation on how to really finish the treatment. So there, another youth issue. And then last month, I got a call, another patient, 22 years old, and she told me, Tita Louie, is it okay if I just lose weight? I said, why? What's the objective? Because I work for an online casino. I need to be pretty. So I told her, did the health center give you any information about proper nutrition, proper physical condition for you to fight the bacteria? She told me, it's more important, my livelihood is more important. I need to be pretty to my online customers. So I told her it's just really unbelievable about the lacking guidance that we have in the policies for these sectors. And before I flew here, of course, Global Fund is now initiating the Protection for Sexual Exploitation, Abuse, and Harassment. Yeah, it will never be role. It'll be my role. As a civil society, I will teach the community how to protect themselves. So I really think that my target of reaching more of the unreached is not really geographic. It's more of the people in front of you are not being given focus. And the enabling environment, it really have to look for ways on how to make these mayors commit so that we can really utilize the new tools that's coming our way so that people won't have to end up like me. I wasn't able to see my kids, but I was able to see my husband. So thank you so much.
Thank you. Thank you so much. It shows how broad and diverse all these different issues is, from the kind of financial issues to the personal challenges and to the broad spectrum of different cultures and backgrounds that and the unreached are really an important factor that we should also integrate strongly in our way of strategy. So there were one question at least, and there are several questions, so I will sort it a little bit, start here. Now the microphone, perhaps you go to the back, there is then a second question at the back, and then we come to the front. It's a little bit technicalities, and we have to be short in your questions, so time is now running short, but we want to have as many questions accommodated, and please also short answers if possible.
Thank you very much. My name is Oanh Quat. I'm from Vietnam. I'm a director of a local NGO. We work also on TB as well as HIV and malaria. So if you can see that, I think we all know that for TB, the diagnosis at the moment is how difficult. If you compare to HIV and malaria, we miss a lot of patients, and it costs a lot of money and effort for people to diagnose. In my country, Vietnam, on average, a patient will need to go twice to another health facility, and then go twice to other service like pharmacy or traditional health before they are finally diagnosed with TB. So the poor people, the people with disability, the elderly, the people who don't speak the language will miss that opportunity.
Yes.
So my question for all of you is that what is the progress now in terms of diagnosis of TB, let alone TB among children? My second question is about investment in community, and I am so glad for some of the panelists talking about that. But the investment in the community system is still, I think, far from sufficient. And investment in community is crucial because of the challenge in diagnosis, in supporting the patient. If you don't invest in the community, I don't think we are going to end TB. Yep. Thank you.
You already almost gave an answer, but who wants to comment on this? I think everybody agrees.
Collect questions, maybe.
Excuse me?
Perhaps easier to collect.
Would you want to?
I think you're suggesting take another and then we can answer.
Yes, right. Yeah. So let's take, we are now down there.
Good morning. My name is Malini Aisola. I'm with the All India Drug Action Network. My question is about two countries that have a high burden of disease when it comes to TB. India has come up during the panel discussions for its efforts to address TB, but we know since at least June of this year, there has been intensifying stockouts of the medication for TB and MDR-TB, and these stockouts relate to, across India, relate to both first-line and second-line drugs and also pediatric formulations, and the government has denied that there is any issue with the supply of medicines. In fact, the center in some instances has asked the state governments to procure the drugs rather than supply from the central government. So I was just, this question is actually for Dr. Sahu to, I was wondering if you're concerned and if something is being done to address this issue. Also related to this is, I wanted to ask a question about South Africa, which has launched this unprecedented investigation against Johnson & Johnson for the overpricing of bedaquiline. So it's one of the countries that is not going to benefit from the price reductions for bedaquiline. I was wondering, waiting for comments from the panel. Thank you.
Thank you. I think we take those two questions, and I ask who would start with the first question to answering.
I can jump in on Vietnam
Yes.
real quickly. And it's in the interest of
Time,
our
yeah.
team to see this end by 12:30 because we're running the next session in this room. So on Vietnam, I'll say I got to visit in Ho Chi Minh City and see that we are supporting the government in order to, we've been piloting with them, bringing the CAD for TB X-ray combined with Gene Expert or mobile systems for on-the-spot diagnosis, and really saw that we are making that work. So a chest X-ray read by AI, immediately giving a result, followed by a test that gets the result to the person by the end of the day, and then started on treatment. So those pieces have been brought together and been deployed. It's of course up to the government to be able to scale and drive that forward, and would advocate that that be done. I'll let Dr. Sahu take on the question about drugs in India, but I would say we are seeing that governments are interested in trying to scale up. Not only in Vietnam, we have 7 countries, Nigeria, India, and others among them, where that is now taking place.
Yes.
Thank you. I'll just start with a quick response to the investment in communities. I think that is key. And we are very grateful to USAID for continued support to the Challenge Facility for Civil Society, which is the biggest mechanism to fund TB communities on the ground. And we now have also France on board. So that is good. We need more donors to come in as well. So then shifting over to India, we have seen reports, I think many of you have seen reports about the drug shortages. We have also seen an explanation from the government, which was put out in the media and everywhere. The way the government has responded, you are right, is that local program managers at the local level could, because the quantities are less, they could procure locally and supply for the time being some drugs which are in short supply. That is the response we have seen. Now, I would also try to point out one thing, which we have to think about the future. I am Indian. When I buy drugs in India, I buy it from the private system, which is beautiful. I think in the future, we should think about, in a country like India, how can the public sector do strategic purchasing of services of the private sector, excellent supply chain mechanism that deliver drugs to the house of the patients. I think that's the future, and more of that we need to see in a country like India. Thank you.
I'm in a very difficult situation now. I see already the flags raised that time is almost over. I apologize, therefore, that we will not be able to have more questions answered in this way, but I'm sure a number of panelists will stay for a couple of more minutes and when you find then please a direct contact with them. I really feel sorry about that, but that is how it is. So this was a really impressive session. Thank you so much to the panelists. Thank you so much to you, the audience, who it's always difficult to get the timing right, but I would have liked a little bit more for more questions. I hope some of you will stay. Thanks again, and it was great. And let's now hope that the future will be as bright as some of you at least indicated. Thank you.